The title of our presentation today is Developing a Knowledge Translation Tool to Facilitate Physical Activity Discussions in Oncology Care. So welcome, and I'm going to introduce Dr. Fong in just a moment. Just want to let everyone know for the Q&A, it should still work fine. Just please, with your question at the end, please send it via the chat box and just chat it to everyone. That's probably the best way to do it. And that way, Dr. Fong and I should both be able to see any questions that come through, and it should be that should be a fine way to do it. Okay, and I've muted everyone on entry, so no worries about that. So, Dr. Angela Fong is a faculty member, instructor of medicine in population science at the Rutgers Cancer Institute of New Jersey and in medical oncology at Robert Wood Johnson Medical School, Rutgers University. Her research program aims to understand the influence of physical activity on psychosocial outcomes in women diagnosed with cancer using novel mobile and e-health interventions. Her work integrates multidisciplinary methods from health psychology and knowledge translation. Dr. Fong has received funding from the Canadian Cancer Society, Canadian Breast Cancer Foundation, and the Cancer Center Support Grant from Rutgers University. So welcome, Dr. Fong.
Thank you so much for the introduction there, Megan. I want to actually highlight the complete irony of the situation in that much of my research actually uses technology, and today I'm having a technological snafu. So Megan, if you
it's one of those weeks.
Exactly, it's one of those weeks, and we're just rolling with it. So Megan, if you could advance the slide for me.
Okay.
And you'll just hit it one more time. So for those that I've presented in front of before, I am a big fan of animations and little things like that. So Megan here will get a little bit of a workout. I just wanted to highlight again my background. So again, I am a kinesiologist or in kinesiology by training. I think like most people in kinesiology, I have this inherent interest in all things physical activity, sport, and exercise. Specifically, a lot of my work has focused on exercise psychology in my graduate career. So I want to understand how to motivate, cancer survivors to become more active. And then again, as Megan said, I look at the psychosocial outcomes of being more active. And hit that again for me, Megan. A bulk of my research actually examines knowledge translation in the context of physical activity promotion, and that's actually specific among breast cancer survivors. And the reason why I do this work is actually it stemmed out of frustration for me, because I knew that in our labs we're creating this really wonderful, impactful, or what I thought was impactful research. And then when you speak to the knowledge end users, so in this case, let's say breast cancer survivors, they are actually really unaware of that work. So I actually shifted in my PhD to look at knowledge translation. And one more time for me, Megan. And this actually led me to, so my PhD, my postdoc led me to my position here at the Rutgers Cancer Institute of New Jersey. And what I'm doing now is using knowledge translation to develop, again, E and M health interventions to promote physical activity. And all of this is done under a knowledge translation framework using knowledge translation methodologies, or as they call it here in the US, dissemination and implementation science. So I may flip between KT and DNI, but just know that I mean the exact same thing. And today what I'd like to do is actually focus on a project that I did during my postdoc. And this led to the development of a KT tool to promote physical activity counseling between oncology care providers and their patients in cancer care. Next slide, please. So I'd like to begin by acknowledging the contributors on this project. So that would be the primary investigators, as well as my mentors, Dr. Thomasoni at Queen's University and Dr. Savastin at the University of Toronto. And one more time for me, Megan. I'd also like to acknowledge our stakeholders who are also our co-authors, and these are the cancer survivor patients as well as the oncology care providers. And again, I'd also like to acknowledge the AGREE methodologist and the research assistant who helped put this project together, and honestly, you will see that it's a lot of work and you really do need all hands on deck. One more time. And finally, I'd like to acknowledge the funders of this project. Next slide, please. So this tool developed because, as I'm sure many of you are aware, there is a high prevalence of cancer globally. Specifically in Canada, the rate of cancer diagnosis is now 1 in 2. Next, please. So there are some common cancer diagnoses. Among men and women, the most common diagnosis is actually lung cancer. And again, among women, the most common cancer diagnosis is breast. And then among men, one more time, it's actually prostate cancer. Within this sphere, though, colon cancer, I believe, is now the third most common diagnosis, regardless of gender or sex. And hit that button again, please. And with the increases in early detection, as well as improvements in treatment and new treatment technologies, the survival rate for a cancer diagnosis has increased significantly over time. And I also just want to say that when I use the term cancer survivor, I'm actually referring to anyone who's been diagnosed. So that term goes from diagnosis right until the end of life. Next slide, please. And so while there are a lot of survivors in Canada, and this is very promising, this also means we have a large population of men and women who are living with the debilitating effects that follow curative treatment. You could hit that button for me, Megan. And then one more time. So cancer treatments are quite harsh, and they lead to a number of what we call treatment-related effects. The first are usually physical side effects. So if you could hit that button for me, Megan. And this can include, increased risk for things like comorbidities, including cardiovascular disease and diabetes. Other physical effects can include secondary cancer diagnoses, recurrence of the same cancer that they were diagnosed with, severe cancer-related fatigue, as well as lymphedema. From these physical effects, there can be a lot of psychological effects. You can hit that button for me. And this can include things like fear of recurrence, cancer worry, depression, and anxiety, as well as post-traumatic stress disorder. One more time. And then finally, there are social support changes that cancer survivors experience. And this can include feeling isolated as they transfer from cancer care back to their primary care provider, and also changed social support networks as they navigate through the cancer survivorship trajectory. So combined, these effects have a rather large effect on quality of life. Megan, if you could hit that button twice for me. Thank you. And so given the number of survivors, we need to think about different strategies in order to mitigate these effects and improve overall quality of life. And I think given my training, it should come as no surprise that one proposed strategy is physical activity. Next slide, please. So before I dive into the literature on physical activity and cancer survivorship, I just want to offer some definitions. So the first is physical activity, which refers to any bodily movement that increases heart rate above resting. So an example of this would be walking around your town in order to complete different errands. You could hit that button for me. Where exercise, on the other hand, is any physical activity that's scheduled, purposeful, and the overall goal is to maintain or improve fitness levels. So another example would be walking at a very brisk pace, scheduling this 3 to 5 times per week, and having each walking session be at least 30 minutes. Between these two examples, walking is obviously used. The former example may increase your heart rate, but it's not planned and purposeful, whereas in the latter example, the intensity, so this brisk pace, is supposed to help increase your fitness levels. So what I'm trying to say is that all exercise is physical activity, but not all physical activity is exercise. Next slide, please. So from the literature, we can understand that physical activity can actually impact a cancer survivor throughout the cancer trajectory. So at pre-diagnosis, there's evidence that suggests that physical activity can obviously prevent cancer through modulation of energy balance as well as through immune responses. Please hit that button. During treatment, there is emerging evidence that supports increases in physical activity lead to increased physical functioning. At this point, we're unsure of the effects on treatment tolerance, but I know there is a budding literature in that area. You can hit that button one more time. Thank you. During the earlier phases post-treatment, so this is about 1 to 5 years post-treatment, we have a really large body of evidence, and this suggests that physical activity can lead to improvements in a lot of different quality of life domains that are listed there. You can hit that button. And then towards the later ends of the treatment spectrum, we see that physical activity can have prolonged effects on reducing comorbidities, secondary cancers, and recurrences. And then finally, at end of life, one more time, please. We can see there actually is a lot of evidence to suggest that physical activity can increase coping for what's yet to come. So it's important to note that this evidence is quite rigorous. Megan, if you could hit that button 2 times for me, please. Thank you. A lot of the evidence is based on randomized controlled trials as well as experimental designs, and there's been very few adverse events reported in the literature. It's important to also note that most of this literature is built off of these 3 different tumor sites, so breast, prostate, and colorectal, mainly based on their higher survivorship rate and also clear endpoints when it comes to treatment. Next slide, please. So we understand that there is a lot of quality evidence, and that supports the benefits of physical activity in cancer survivorship. Driven by this evidence, researchers have developed cancer-specific exercise guidelines. You can hit that button for me, please. So in 2010, the American College of Sports Medicine released the first set of exercise guidelines, and these guidelines actually mirrored public health guidelines at the time. So Megan, if you could hit the button 3 times for me, please. Thank you. So the recommendations were to aim for 115 minutes of moderate to vigorous physical activity. So that's intensity such as walking at a brisk pace. So you want to be walking as if you're late for a meeting. That's about moderate. Running would be considered vigorous. And it also included some recommendations for engaging in resistance training, and that survivors should try resistance training with major muscle groups if they felt comfortable. And there was also a recommendation for being supervised while they were exercising for safety reasons. Again, if you could hit the button 2 times for me, please. Thank you. And so in 2017, Cancer Care Ontario actually released updated guidelines building off the 2010 guidelines. And these guidelines offered very specific recommendations. So Megan, if you could hit the button 3 times for me, please. Yep. And the recommendations were to add a warm-up and a cool-down session. This was actually to maintain safety while exercising for the cancer survivor. They also gave specific dose in terms of frequency of sessions for both aerobic and resistance exercise. And they also offered specific sets and repetition recommendations when it came to resistance training. Megan, if you could hit the button 2 times for me, please. Yeah. Oh, and one more time. Thank you. And then just this last year, the American College of Sports Medicine released an updated census statement with guidelines. And these guidelines were actually more prescriptive. So based on the literature, there are some outcomes related to cancer that we have a lot of support for. So these guidelines are for these specific outcomes. And the prescriptions are based on targets for training heart rate, ventilatory threshold, and rates of perceived exertion. Next slide, please. So at this point, we have a strong evidence base which supports the benefits of physical activity for cancer survivors. There have now been 3 exercise guidelines that have been developed and disseminated. And one would hope that the physical activity levels of cancer survivors would be similar to that of the general population. And as you can see in this pie chart, that's actually not the case. So Megan, if you can hit that button for me. So upwards of 88% of cancer survivors report and have been objectively measured to not be meeting these physical activity guidelines. If you could hit the button 2 times for me, Megan. And to contextualize this, the general population is about 50% of individuals are meeting physical activity guidelines, so this is actually pretty significant. And this said to us as researchers that we need to develop strategies to promote physical activity among cancer survivors so that they can, in fact, meet these guidelines. Next slide, please. So one potential efficacious strategy is to use oncology care providers. You can hit that button for me, Megan. For the purposes of this project, we operationalized an oncology care provider as any health professional who is responsible for cancer care. So this can include physicians, nurses, nurse practitioners, allied health workers, as well as social work. If you could hit that one more time. And the reason why we wanted to look at oncology care providers was because they play a relatively important role and are key influencers in motivating and supporting their cancer survivor patients to become more active. And again, so in breast cancer survivors, we see that if an oncology care provider recommends becoming more active or engaging in more physical activity, breast cancer survivors actually increase their physical activity. And one more time. Overall, we see that oncology care providers have rather favorable attitudes towards physical activity in that they understand that that physical activity is beneficial for their patients and that it's safe for their patients even if they're engaging in active treatment at the time. And one more time. However, despite these positive attitudes and opinions, oncology care providers do not consistently counsel or discuss physical activity with their patients. For the purposes of this project, we operationalized physical activity counseling as any discussion related to physical activity occurring between an oncology care provider and their cancer survivor patients. Next slide, please. So we wanted to understand why physical activity counseling wasn't happening in clinical practice. And we found that oncology care providers are facing a number of barriers. Megan, if you could hit the button 3 times for me. So they have a lack of time in clinic. So clinic visits are relatively short to begin with, but on top of that, oncology care providers are spending a lot of time focusing on treatment, when treatment is happening, and then the effects of the treatment itself, and feel that they didn't have time to discuss the role of physical activity. They're also uncertain of what to recommend. So again, we have these 3 guidelines. They all say similar yet slightly different things. If you're not in the physical activity world or do that type of research, it can be very difficult to discern what to tell their patients. And then finally, they believed that physical activity counseling could itself be a very complicated behavior. So understanding this, myself and colleagues examined ways to facilitate physical activity counseling. Megan, again, if you could hit the button 3 times. Yep. And they believed that in order to discuss physical activity in clinic, they would need education sessions to understand the current literature and the guidelines. And they wanted these sessions to be rather short, and paired with something fun like a lunch and learn. They wanted tools that were simple and easy to use so that, again, we weren't adding too much to the already constrained clinic visits. And then finally, they wanted these strategies that would be, initiated by oncology care providers, but not dependent on them. So perhaps initiating the discussion and then referring the bigger counseling piece in terms of recommendations to a nurse practitioner or a registered kinesiologist. So from this body of evidence, it's clear that the strategy that we're developing actually needs to be targeted towards the oncology care provider so that they're able to have these discussions with their cancer patients because of the important role that they play. And it's actually important to note that this type of work aligns with a call to action that's been released from the from the ACSM, and it noted that oncology care providers are integral to physical activity counseling and that they actually need to almost step up to their role. Next slide, please. So when we're discussing knowledge translation science, it's obviously best to suit it within a framework, and obviously I'm going to be using the knowledge to action framework. Within this context, we see that the guidelines were developed in the knowledge funnel. So the inquiry was based on the efficacy of physical activity on cancer-related health outcomes. You could hit that button for me, Megan. Okay, and 2 more times, please. Okay. And this led to many systematic reviews and meta-analyses. And if you could hit it 2 more times. And that led to the development of these 3 exercise guidelines, which are in fact our knowledge tools. Next slide, please. So when we turn the knowledge creation funnel around, we then looked at examining how the knowledge was being used in clinic through our previous work, and we noted a number of reported barriers and facilitators to this knowledge. You could hit that button for me. Yeah. And with the 3 guidelines that currently exist, we can see that the informational environment is actually quite complex and it's really difficult to navigate. And in creating these 3 knowledge tools, we actually have this slightly larger gap. We could go to the next slide, please. Megan, I'll have you hit the button 3 times. Thank you. And so the specific knowledge to practice gap is represented as follows. So we have this knowledge in terms of there's evidence supporting physical activity for cancer survivors. We understand that it's safe. Oncology care providers also understand this information and that it's valuable. But the gap is that the oncology care providers who are important in health of their patients are not in fact discussing physical activity with them. So what we needed to do was to develop a knowledge translation tool. Next slide, please. So going back to the action cycle phases, what we then wanted to do is actually turn the knowledge funnel and look at how the guidelines were being used in the local context. And again, if you could hit that again. And what we wanted to do was be able to adapt how the knowledge is being used using our tool. Next slide, please. So using an integrated knowledge translation approach, what we did was we had several discussions with oncology care providers from all over Southern Ontario. And if you could hit that button 2 times for me. And we formed a stakeholder group that consisted of patients and clinicians. And from these discussions, we determined that what they really needed was a tool to actually remind them to discuss physical activity. Because again, there was constraints in clinic. And so we worked with a graphic design company. If you could hit that button for me, Megan. And we developed what we're calling a prompt. So the prompt is made of wall decals that are designed to remind an oncology care provider to discuss physical activity. So we had various different types of hues to represent physical activity and movement. We wanted this idea of movement because, you know, some cancer survivors may not be ready to go outside and start running, but they may be ready to start walking around the block to at least initiate physical activity. And we had this idea of the term anytime because we wanted to focus on physical activity throughout the cancer trajectory. So again, we worked with our stakeholder group and a graphic designer developed this tool, and then we asked for some feedback. Megan, if you could hit the button twice. Great. And the feedback was, unfortunately, they did not like it. It did serve a purpose in terms of creating a reminder. However, the reminder would be from both the oncology care provider seeing it and remembering, as well as the patient wondering, you know, what these decals are doing on the wall. So in an attempt to try to bridge this gap, we actually created a different gap in that oncology care providers would be prompted to discuss, but they didn't actually know what to say. Megan, if you could hit the button 1 more time. Great. And so moving forward, we realized that the tool was not necessarily this idea of a prompt, but a tool to actually facilitate the resulting conversation. We could go to the next slide, please. And again, if you could hit the button 2 more times for me. Yep. So the purpose of the project was to develop a knowledge translation tool to facilitate physical activity counseling between oncology care providers and their patients. Again, we used an integrated knowledge translation approach, as well as we were guided by the Agree To. So I won't go into the Agree To in too much detail, but essentially it's a gold standard for developing clinical guidelines. And the reason why we wanted to use the Agree To is because it's been used in clinical and cancer care practice. And we were hoping that if oncology care providers saw the Agree To symbol on our tool, or if we could say that it was using the Agree To, that they would in fact agree that it would be a good tool to use in their current clinical practice. And in order to conduct this research, we used mixed methods, including group discussions and cross-sectional questionnaires. Next slide, please. And Megan, I'll have you hit the button one more time. So if we go back to the action cycle, we've now shifted and we're looking at how the information from the exercise guidelines can be used to select, tailor, and implement the intervention. And in this case, it would be our knowledge translation tool to facilitate the discussion. During my postdoc, my original goal was to develop the tool. So at this time, I thought it was the prompt, test it in clinic, and then finish out the rest of the phases of the action cycle. But unfortunately, we were running out of funding as well as time. So my postdoc ended up focusing on the development of the knowledge translation tool itself. Next slide, please. Great. And if you could hit it one more time. Yep. So the resulting knowledge translation tool or recommendation guide is a 5-page tool that begins with a preamble. And I'm actually going to put the cart before the horse a little bit here and show you the tool that we developed and then go back and briefly discuss how it was developed. So the purpose of this tool is actually to screen individuals based on their comorbidities and current physical activity and functional capacity, and then recommend appropriate physical activity resources and programs. So when we think back to the beginning of my presentation, I noted a number of effects that occur after treatment, and some of these effects may be so severe that there are actually contraindications to physical activity. So Part A of the recommendation guide screens out anyone where exercise may actually not be appropriate for them at the time. Next slide, please. Yep. And so for individuals who pass Part A, we then move into Part B, which is a list of common comorbidities for cancer survivors and physical activity and functional capacity assessments. Based on our discussions with oncology care providers and stakeholder groups, these two categories were considered really pertinent to them. And if you could hit the button for me. Thank you. And if you could hit it one more time. So this functions as a checklist where based on frequency, survivors would be categorized into red, yellow, or green levels. And if you could hit this, the button twice for me, please. Thank you. So if we think about, actually one more time. Thank you. So if we think about a pretend patient, this patient could come in presenting with the following comorbidities. So they're on medication for their heart. They have some neuropathy as a result of treatment, as well as arthritis, and some mild to moderate balance issues. So when we do a frequency count, we see they mostly fall under the moderate category, so that's where we'll categorize them for the time being. And if you could hit the button 2 more times for me, Megan. On the physical activity and functional side, we see that this pretend patient has not been very active in the past 6 months. They're able to engage in some walking and in self-care, so they again would fall under the moderate capacity. Again, next slide, please. And in Part C, this is where we would try to bring everything together in a contingency table. Megan, if you could hit the button 2 more times for me, please. So we recall that they fall under a moderate risk for both comorbidities and their physical activity and functional capacity. So when we put it together, we would see that they could go to one of these programs, a cancer and exercise program, as well as they would qualify for receiving physical activity resources. Next slide, please. I was very lucky to be in a lab where we had a really diligent master's student. And as part of her master's thesis, she developed a casebook of all exercise and recreational programs for cancer survivors in the province of Ontario. Actually, as I'm saying this out loud, I think this is actually part of, it wasn't actually her master's, it was a side project that she did, again, showing how diligent she truly is. And so we were actually able to create Part D quite easily because we populated this list with the work that she had already done. So going back to our pretend cancer survivor, they were under a moderate risk, we did the contingency table, and they qualify for Program D. So Program D is for lower risk patients. And then we would also give them some online resources for physical activity as well as paper resources available at the patient library at the hospital. So now that you have a clearer idea of what this recommendation guide looks like, let's go and actually look at how it was developed. So Megan, if you could hit the button twice, we're just going to advance through the one slide. Yep. And then if you could hit it 3 times for me. So to develop the recommendation guide, we first formed a working group consisting of myself and the 2 project primary investigators. And this group was responsible for guiding the project, developing the initial idea, and then making decisions related to any feedback we received. We then had to obviously create the assessment or develop the assessment criteria, and we did this based on an evidence review. And then finally, the target population for the recommendation guide would be the cancer survivors, and the target users would be oncology care providers. Okay, and next slide, please. And again, you'll hit the button 4 times. So as I alluded to earlier, we did form a stakeholder group, and this consisted of cancer survivors as well as oncology care providers. The oncology care providers were a medical oncologist, a medical oncology resident, a general practitioner in oncology, and a radiation oncologist. And, a general practitioner, family doctor, not in oncology. And these individuals came from various parts of Southern Ontario, so we could get different views about what they needed in clinic. And although this person wasn't part of the stakeholder group, we actually consulted an agree methodologist throughout the development process. We crafted an initial development plan and then presented it to the methodologist so they could give us some guidance, because again, we were using the agree to, but we were not actually creating a clinical guideline. So there were some nuances that needed to be adjusted. And anytime we had any questions, we could consult this individual. And then finally, we had the methodologist facilitate the agree appraisal process, but they did not participate in the appraisal process. And we also included external reviewers. So external reviewers were familiar with the broader research topic, and they had clinical experience in cancer rehabilitation. They were not part of the development process other than being part of the review portion itself. Next slide, please. And Megan, you'll hit the button 3 times. So to develop the recommendation guide, we took these 3 steps, and I'll just go through each of them individually. So if you could hit the button 2 more times, please. And 1 more time. So in the stakeholder meeting, it was 1 day, and this is where we developed the scope and purpose of the project. Megan, if you could hit the button 3 more times. And what we did was we presented the stakeholders with existing physical activity screening tools from the literature. And what we found was that the group was not overly happy with these tools. They found them rather cumbersome and that they lacked additional details related to functional capacity as well as physical activity. So through consensus, we identified that comorbidities, physical activity, and functional capacity were the 3 key areas. Another finding that developed from our stakeholder meeting was that we had a bit of a name change. So originally we had called the tool a decision aid, but oncology care providers said that this was a really inaccurate name because to them, a decision aid is actually a clinical guideline. So to avoid the confusion, we decided to call the tool a recommendation guide. And then finally, the stakeholders offered guidance on the evidence review that would create the checklist. Next slide, please. So Megan, you'll hit the button 2 more times, please. Thank you. Specifically, the evidence review consisted of reviewing the peer-reviewed literature in order to extract study eligibility criteria. So we looked at physical activity intervention studies for cancer survivors and then took out any of the criteria that they used. We also contacted some authors to clarify on what they meant by specific criteria, such as medical clearance and things of that nature. The group also agreed that we needed to look at pre-existing programs and talk to other content experts in order to understand or populate the list with criteria that maybe we wouldn't see in the literature. So with or using Google, a targeted Google search, we did a web search to find programs, and then we either downloaded the screening tools that the programs used, or we contacted program coordinators to get that information. And the content experts, we had consultations over email as well as in person and discussed the criteria that they use in practice in order to screen individuals for either engaging in physical activity or increasing physical activity. Our content experts included a physiatry resident, physiotherapists working in cancer rehabilitation and with persons with physical disabilities, as well as a program coordinator for a community-based physical activity program for persons with physical disabilities. Next slide, please. Megan, you'll hit the button 3 times, I think. Yep. So from our various sources, we then extracted the eligibility and screening criteria. We then synthesized the data and organized it based on where the criteria affected the body. So for example, criteria such as presenting with heart failure, having cardiovascular disease, or the use of heart medication will be grouped under cardiovascular disease. We found a total of 22 unique criteria. The criteria were then categorized as high, medium, and low levels based on the National Comprehensive Cancer Network Physical Activity Screening Guidelines. We then developed the first draft by creating the assessment checklist as well as the contingency table. And then through a multi-step iterative process, we sent the draft out for feedback. So we first received feedback from the stakeholders, integrated the feedback, sent it out to the external reviewers, integrated their feedback, and then developed the final guide. Next slide, please. And if you could hit the button one more time. Thank you. So during the feedback process, we asked the stakeholders and external reviewers for comments on the clarity of the recommendation guide itself. Groups were emailed an updated copy of the full recommendation guide with the 5 pages, given a summary of the development process, and then asked to offer feedback through a questionnaire. So the questionnaire, we used purpose-built items, and they were anchored at number 1, strongly disagree, and 7, strongly agree. Stakeholders who were cancer survivors completed the same questionnaire, but the items were modified based on whether or not they thought the guide would be helpful and if they were comfortable seeing the guide in practice. And overall, the stakeholders agreed that the recommendation guide would make it easier to discuss physical activity either as an oncology care provider or as a patient. They thought it would fit into practice and it would benefit practice. Next slide, please. And if you could hit the button 2 more times, please. Okay. Similarly, the external reviewers also agreed that the recommendation guide would be easy to use, that it had enough information and would actually benefit practice, as highlighted by the red boxes. External reviewers believe that the recommendation guide could be used in practice without additional consultation. And this is interesting because oncology care providers were more on the fence about this finding. If we go to the next slide, please. We also asked the stakeholders as well as the external reviewers for their opinion on presentation. So we knew that we would have to have a full version of the recommendation guide available, let's say, in a paper format or online, but that we wanted a easy-to-use referral piece, and we wanted their recommendations on what to do or how that would look. So the first was an index card. So if you could hit that button for me, Megan, that would just have the checklist and the contingency table. And if you could hit it 2 more times. And then the second was a brochure that would, again, have that same information and be easy to bring into practice if needed. Next slide, please. Thank you. So in the Domain 5, we outlined some proposed plans for applicability. And each of these plans have an implication for different phases of the action cycle. And I want to also stress, too, again, we were running out of funding at this point, so we weren't able to fully initiate this plan, but had thought it through. So if you could hit the button for me, Megan. So the first was that using the recommendation guide in clinic would have an effect on time constraints, which we understood. Stakeholders who are oncology care providers suggested that the recommendation guide could be a way to initiate discussions with cancer survivors, but that they would prefer someone from the allied health member team or a social worker to actually follow through with the recommendation guide piece. If you could hit the button for me, please. Okay. In order to implement the recommendation guide into clinical practice, we understand that training may be needed because it's not as innate as we would have liked. So we developed plans to develop a variety of training platforms, including a video, online modules, as well as print materials, and then also offering presentations and sessions at grand rounds to discuss and show how to use the tool itself. Next, please. Thank you. We also recognize that the recommendation guide itself could be rather resource intensive. So for instance, printing materials takes time and money, the additional time demands for the oncology care providers and supporting staff members to use the guide, learn how to use the guide. So we acknowledge this in our Agree to report. Next, please. And then finally, we actually didn't develop auditing criteria specifically for the recommendation guide. We proposed instead a mixed methods pre-study, post-study design to measure the feasibility and acceptability of the recommendation guide among both oncology care providers and cancer survivors themselves. And actually, this is an area where the agreed to methodologist was quite helpful in that because it's not a clinical guideline, it's very difficult to understand how it will be used because it's not regulated. So we discussed how we could address this area of Domain 5 without overstepping the bounds and the purpose of the recommendation guide. Next slide, please. Megan, if you could hit the button 3 times for me, please. So in the last domain, we used a modified form from McMaster in order to disclose any conflicts of interest. So we stated that the funding agency didn't have a role. We acknowledged the fact that we engaged an agreed methodologist, but that they were not involved in the appraisal process. And then we acknowledged some overlapping publications that we had pulled out from the literature where some of the co-investigators were actually authors on those publications. Next slide, please. So the Agree methodologist helped us coordinate the actual appraisal of our Agree report for developing this guideline. And from the 2 Agree methodologies, the 2 other Agree methodologists, these are the findings from their appraisal. So we can see that, actually, Megan, if you could hit that button for me, please. Okay. That most of the domains are above an acceptable 70% cutoff score. So that cutoff score comes from the Agree to manual, although they do state that you can use it based on, or you can adjust it based on field specifications. Seeing as something like this doesn't exist in the literature right now, we didn't have cutoff, so we decided to use 70%. And so these areas come as to no surprise to me that they did quite well. Where we didn't do as well, not surprisingly, is Domain 5. Megan, if you could hit that button for me. Thank you. One more time. Is here, again, it's because we didn't have solid plans or of how we could inform the applicability. They were more so ideas, and I'm sure they could have used additional details based on the feedback that we received. All right, Megan, next slide, please. So with any tool development, there are some limitations in strengths. With the approach that we used, Megan, if you could hit that button, the limitation is that, again, we had this lack of auditing like criteria, and this may in fact impact uptake. However, on the flip side, a strength, hit it one more time, would be that we actually engaged an agree methodologist throughout the process, which I think really helped clarify on what the different items meant in the agree to and how we could modify them for our context. And we also were able to conduct the external review, which I think is quite helpful because we would get additional feedback from individuals who were not embedded in the development process. Megan, if you could hit the button one more time. Sorry, two more times, I lied. Limitations of the recommendation guide itself were that at the time we weren't able to evaluate the guide itself for feasibility and acceptability, although that may be in the works. And again, this evidence may not be applicable to all survivors. So earlier I had said that the literature is primarily focused on breast, prostate, and colorectal cancer survivors. So for lesser diagnosed cancers or for cancers with lower survival rates, some of these recommendations may not necessarily suit. Again, that's why we built in the Part A with the screening out process, but it's sad that we can't actually recommend any sort of physical activity at that point. One more time, Megan. And then a strength would be that this recommendation guide itself actually represents current evidence and practices based on our literature search as well as our various other sources of evidence. Next slide, please. So in terms of future directions, Megan, if you could hit it 3 more times. We are in the process of developing, or actually, sorry, we need to actually develop an auditing criteria and how that could potentially look in the context of physical activity discussions. We're in the process of testing the prompt and the recommendation guide. I'm hoping that we'll have some evidence for that from that in the next year or so. And then once we have that pilot data and can understand the feasibility and acceptability and adjust where needed, I'm hoping we can actually have a large multi-site efficacy trial that could be cross-border. So have individuals in Southern Ontario testing the recommendation guide in their clinics, and then I would like to test it here at the CINJ. And it'd be really interesting to compare a private healthcare system, so where I am, to a public healthcare system and examine how the recommendation guide actually fits in both of those different clinical contexts. Next slide, please. You'll hit the button 3 times, please, Megan. And so some final take-home messages from my presentation in that consulting and agree methodologists is definitely the way to go because they can help clarify on different items. Engaging a diverse group of stakeholders and reviewers is really helpful to get that feedback, especially since the way that you view evidence even can be quite different. And then finally to gather data from different resources. And I think I'm going to skip the last slide, and if we could just go to the end because I'm realizing the time now. So I wanted to thank everyone for their time, and I open the floor to any questions.
Awesome. Thank you so much. So it looks like we had a question from Queens there. I'm not sure if you can see it.
Yes.
So it says, thank you for sharing your work. What advice do you have for anyone who may want to use the agree to for KT tool development in the future, i.e. if you could go back and do it again, what do you wish you knew when you started?
So I'm going to reiterate my first piece of advice in that definitely engage an agree methodologist. Again, they know this tool so much better than individuals who just aren't in that world, myself included. If I could go back, what would I do? I would definitely give myself way more time than I thought I needed. The agree to obviously is very strong and has been used so many times. As I was going through other papers that had used the agree, a lot of the times they use it to guide research and guide their development process, which is fantastic. But if you're going to use the full agree to development process, including the appraisal and whatnot, you really need to give yourself a lot of time. So if I could go back, I would definitely add, I would say 4 or 5 months of extra time just to accommodate developing the tool.
Awesome, thank you. Let's see here. I have a couple questions here as well. How do you plan on addressing in-clinic barriers when implementing the recommendation guide?
Excellent question. So the original way that, or actually the proposed feasibility and acceptability trial that we're developing right now will actually start with focus groups. I think they're either going to be focus groups or one-on-one interviews to understand what other barriers are existing in clinical practice. I know specifically with my group in New Jersey, the discussions I've had is, you know, we don't have time, and we're looking at where we can slip this in either as a reminder through the EMR or in the actual physical file to at least address that portion. But I'm hoping that the focus groups will elucidate some other barriers that we haven't thought of. And I think similar to my previous work, we'll combine that with facilitators to these barriers and kind of use a problem-solving method in the focus group.
Okay, thank you. I have another question here. What were some challenges you experienced while developing the recommendation guide, and how did you overcome them?
That is a great question. So I think one of the biggest challenges was actually balancing different dynamics. So in our stakeholder group, it was, as I'm sure you'll remember from the slides, but mostly oncology care providers and then 2 breast cancer survivors. And I would like to state that was not done on purpose. We tried to reach out to a lot of survivors, and it was just, these are the only 2 who were available and willing to participate. So balancing the dynamic between having 4 oncology care providers, 3 researchers, and 2 survivors in the room was rather difficult, especially when you want to obviously take in as much information as you'd like, but give everyone equal say. Another thing was semantics and understanding what you mean. So again, when I was speaking about physical activity, the working group understood what I meant by that. The oncology care providers thought I was talking about intense, you know, CrossFit-like activities, and then the survivors, you know, were unsure. You know, when I said physical activity, did that mean going for a walk to do my groceries, or did that mean engaging in like a class or something? And then another thing was balancing all these different paradigms. So when we're thinking about physical activity and health, oncology care providers see it from this really strict biomedical, medicalized way of seeing things, in that there's an outcome and we're trying to fix the outcome. And then researchers, and I think the breast cancer survivors that were on the stakeholder group, we're really seeing it from a more sociological perspective, in that how do they make themselves whole again? How do we make quality of life better? And it was really hard, especially the fact that I was just, you know, in my postdoc. It was really hard to balance all of those things at the same time. So that's my biggest challenge.
Okay, thank you. So I haven't seen any more questions come in via the chat. Did you have any final comments you wanted to make that you didn't have time for?
I don't think that I do. I mean, I hope that this offered a little bit of information about how you can go about developing tools in clinical practice with respect to physical activity. But I purposely have my email and Twitter on there because I'm hoping people will reach out in terms of their feedback and their thoughts. I'm actually really open to how, like, understanding how to make this tool better, and would love to chat about that. So that's kind of my big push there.
Awesome. Well, thank you so much. Thank you for bearing with me as we had some strange technical issues, but hopefully it wasn't too clunky. So yes, thank you so much. What a great presentation. And I just want to remind people to fill out an evaluation if they could. The online one is great, and I'll resend that link. And our next session will be April 9th with Dr. Christine Cassidy, and her presentation will be on working collaboratively within the health system, lessons learned from an embedded KT scientist. So again, thank you, Dr. Fong, and thank you to all our audience for tuning in.
Thank you so much.
Okay, take care.